All right. It is my pleasure to introduce today's speaker, Dr. Bernie Sunwoo. Dr. Sunwoo hails from Australia originally, where she did her undergraduate and medical training at the University of New South Wales in Sydney. She then went on to complete her internship and residency in internal medicine in Australia. And she liked doing it so much that then she came to the University of Massachusetts, where she was also a resident in medicine, American style. And I'm sure started out far ahead of her peers. After that, she completed her pulmonary critical care and sleep medicine training at Penn and stayed on the faculty at Penn for a number of years. She then felt the siren song of the West Coast and went to UC San Francisco. We were thrilled to recruit her to UCSD in 2017. Dr. Sunwoo excels in the tripart mission of academic medicine. She has won teaching awards at every institution where she has ever set foot, and also received a National Clinician Educator Award from the American Thoracic Society in 2022. Dr. Sunwoo really is a doctor's doctor. In addition to being an outstanding pulmonologist, she is medical director of the UCSD Peter C. Farrell Sleep Center of Excellence. She is widely published and a very in-demand speaker. And we're thrilled to have her speaking with us today. Dr. Sunwoo.
Thanks, Jack. Wonderful. Look at us. I'll mainly look at you guys, but I do need to screen. So I have no relevant disclosures. So my goal today was to use a clinical case to try to highlight and answer the common questions I get in diagnosing and managing obesity hypoventilation syndrome. But if there's three take-home messages I hope you leave here with, it's as shown here. So we need to improve timely diagnosis of OHS. I'm hoping that you will look at patients' weight, measures of hypoxemia, especially during sleep, the serum bicarbonate as possible clues to improve diagnosis. I'm going to try and convince you that a sleep study's role is not so much in diagnosing OHS, really into phenotyping these patients into those who have obstructive sleep apnea and those who don't, which is important when we decide how to treat these patients. And then finish by trying to convince you that we should be using a multimodal approach to target a greater than 25% weight loss in these patients to try to improve that. So I said, I'm going to use a clinical case for this. I decided to use a patient that starts in the inpatient setting. I felt for our medicine folks who will probably relate to it a little bit more. So this was a 32-year-old male. He had somewhat of a subacute presentation. So he presented to the ED with several weeks of worsening shortness of breath, orthopnea, wheeze, lower extremity edema. He had some sick family contacts. Maybe he was feeling a little congested. And so when he was in the ED, he was hypoxic, maybe 80% on room air. The ED put on a non-rebreather, but he was able to be pretty quickly weaned to 2 liters. On exam down in the ED, there was some wheeze. So he kind of got treated for an asthma exacerbation, got put on bronchodilators, steroids, antibiotics, diuresis. Was felt to be safe enough to be admitted to the medicine floors. But on the floors, he continued to be managed as suspected asthma, COPD, heart failure, possible pneumonia. So he continued to get, again, steroids, antibiotics, diuresis. And then around day 5, we were called, mainly because of ongoing difficulties meeting oxygen, especially at night. So his past history was notable for it. He had a BMI greater than 8, had an attempted lap band, which was removed in 2013. He carried a history of childhood asthma, which was being managed with albuterol intermittently, did have hypertension, prediabetes. He struggled with lymphedema, chronic venous stasis, and also had a history of depression and alcohol abuse. His home meds are listed here. They included losartan, citalopram, and a nasal spray. His social history was significant for he did smoke cigarettes, up to 4 cigarettes a day. He had quit 2 years prior to presentation, was also smoking the hookah socially. Thankfully, he had quit the alcohol abuse prior to presentation. So these were some of the diagnostics when he presented. You can see that he had a mild leukocytosis, mild anemia, His chemistry is notable for a serum bicarbonate of 27, but normal renal function. His procalcitonin was borderline elevated, a negative BMP troponin. They did swab him with some of his URI symptoms. It was negative. They did a lower extremity duplex because of edema. It was pretty limited, but no obvious DVT. This is his chest X-ray, highlighting some of the challenges caring for these sucrose agents. You can see that lung fields could not be captured on one film, so he had two films, but it was read as maybe some cardiomegaly and some mild pulmonary. With his history, I will say I find assessing volume status in someone with a BMI incredibly challenging. They did do an echo, and it too was challenging, suboptimal images. But grossly, his LV looked like it was normal, with normal systolic function. He did have mildly reduced RV function with normal size, and his pulmonary pressures couldn't be measured. And then when our pulmonary colleagues saw this patient, we like to get spirometry. So he had inpatient spirometry. I don't think this pointer works, but you can see that he had a preserved FEV1 and FVC, but a parallel decrease in his FEV1 and FVC. We didn't have lung volumes, but his FVC was less than 50% predicted. And a gas was obtained at this point, which showed he was hypercapnic, but compensated. And it was done on 8 liters, so his PaO2 was 114. So I think, we got called because the team had concerns for sleep apnea and specifically obesity hypoventilation syndrome. So our first job was to see if this patient did meet the criteria for OHS. And the diagnosis of obesity hypoventilation syndrome really goes to the definition of it. It's largely captured in the name. Right? So these patients are obese, and we traditionally use a BMI of 30 or greater, understanding that that the BMI is not a perfect capture of adiposity, and especially the distribution of adiposity. These patients have to have daytime hypercapnia. So you want to see a gas showing a PaCO2 of 45 or greater. And as pulmonologists, what we're really trying to do is make sure that there's not another cause to explain the hypercapnia. So what we're really trying to do is make sure that there's no pulmonary disease, especially if it's lung disease. Again, this patient had a history of maybe asthma, was being treated for wheeze. We want to exclude neuromuscular and chest wall disorders, metabolic disorders, and other central hypoventilation syndromes. What there's a little bit of controversy about, though, is whether sleep disordered breathing is a part of the definition. I will say these patients have sleep disordered breathing. The difference is that the phenotype can be different. So 90% of these patients will have your garden variety sleep apnea, that repetitive obstructive collapse of the upper airways. But in about 10% of patients, you won't have those discrete airflow limitations, but you just see them have small tidal breathing. There are some in the field who suggest we need to revisit our definition of OHS, saying that relying on one single ABG and a PaCO2 is too restrictive. So some in the field have argued that we should use the calculated arterial standard bicarbonate as a better reflection of long-term ventilation, much like the HbA1c is for diabetes. So this was from a UK group, but they proposed that in obese patients, in addition to a PaCO2 of 45 or greater, we should think about including a base excess greater than 3 or a standard bicarbonate greater than 7. Some of this came from their own work. So they did a study where they took 71 obese patients without obstructive lung disease, and they did gases on them. And they grouped them into one of 3 groups. So they either had a normal PaCO2 and base excess. They were either hypercapnic with an elevated PaCO2. And then there was a third group that had a normal PaCO2 but an elevated base excess. And in this cohort, they went on to do 2-point ventilatory responses to hypoxia and hypercapnia, as well as a type 3, which is essentially a portable sleep study. And what they found was that that group with the normal PaCO2, but the elevated base excess, had ventilatory and sleep measures that kind of fell between the normal and the hypercapnic group. So they were kind of an intermediate group. And so they proposed that this group might represent an early OHS group. Now, These patients weren't followed, so we don't know if they went on to develop daytime hypercapnia. But in doing so, they're kind of suggesting that OHS is a spectrum. And this concept of obesity hyperventilation syndrome being a spectrum was adopted by the European Respiratory Society. So in 2017, they did a staging schema for OHS, where you can see that 0 was they're obese and have sleep apnea, but no hypercapnia. They started to call them stage 1 and 2 if they're obese, have sleep disordered breathing, and some evidence of nocturnal hypercapnia. And they discriminated between 1 and 2 based on the bicarb. Once they started to develop daytime hypercapnia, that's when they said this patient has obesity hypoventilation, and they reserved the term OHS for those who had daytime hypercapnia as well as cardiometabolic comorbidities. And so, again, in doing so, they're kind of suggesting that is OHS the most severe end of the spectrum of obesity-related respiratory compromise. There are others in the field who say, well, you can have the same patient with a BMI and only a subset will develop hypercapnia. Is it a distinct disorder? I don't need to tell this group. We struggle with obesity. It's kind of humbling, but it's projected in 2030, it might be close to 50% of US adults who are obese as you're eating. So there's not a lot of prevalence data on OHS in the general population. Most of the epi data for OHS studies patients who are being referred to a sleep clinic for suspected sleep apnea. And in that population, it's estimated maybe 10 to 20%. So Babak McCleshey, who does a lot of work on OHS, tried to use our current epi data to estimate who amongst the US adult population what's the prevalence of OHS. So if we know that in the general US adult population, from the CDC, we know that about 7.6 are severely obese with a BMI greater than 40. We know from my sleep apnea literature that about half of these may have sleep apnea, and I just mentioned of this, maybe 10 to 20% have daytime hypercapnia. Then the general prevalence may be close to 0.5%. So it's there. How do we pick these patients up? So this is an older meta-analysis that looked to identify predictors of hypercapnia in obese patients who had sleep apnea. And you'll see that the results here are shown in multiple studies subsequently, but the BMI. So I'm going to try and convince you the weight matters, right? So this guy's BMI of 80 should have alerted you to think about this. They found that measures of sleep apnea, particularly hypoxemia, were associated, and then restrictive physiology, which I'm going to try to convince you is probably also related to central adiposity. So this is a figure, again, showing the percentage of patients with sleep apnea who have daytime hypercapnia sorted by BMI across 4 countries. And the US is shown here in the peach color. The others are European countries, but no matter what country you live in, the higher the BMI, the more likely you are to have daytime hypercapnia. Once your BMI hits 50 or greater, it's being shown that maybe 50% of those patients have daytime hypercapnia. So again, this patient had a BMI 80, we should be thinking about it. So hopefully I convinced you that obesity is associated, I mean, it's in the name, right? OHS. But how does that lead to the daytime hypercapnia? And it's probably multifactorial, but these are the 3 main mechanisms that have been proposed. So we know that obesity causes impairment in respiratory mechanics. It seems to impair central ventilatory drive. I'm going to convince you that the sleep disordered breathing may lead to the hypercapnia as well. So these patients have reduced lungs and respiratory system compliance. They breathe at low lung volumes. So if you were to do pulmonary function testing in these patients, you're going to see restrictive physiology. The most common finding you're going to see for the fellows, it's always on the boards. It's a significant reduction in the ERV, the expiratory reserve volume, and the functional residual capacity. These patients can breathe, the FRC can approach their residual volume. There is a small reduction in the vital capacity and total lung capacity, but it's usually not as dramatic. And so For our patient, we did spirometry and I showed you what those values were. For the fellows and the residents, I think, again, I had to convince you this is a diagnosis of exclusion. So one thing we had to do was, did we feel comfortable saying that this was what we think is restrictive physiology? We don't have lung volumes. Could this be all explained by obesity? Because again, this is a diagnosis of exclusion. There is some data that have tried to quantitate or look at the correlation between BMI and pulmonary or lung volumes. This is an older study by Jones, but you can see that with the change in BMI, there was kind of a linear decrease in the total lung capacity and vital capacity. As I mentioned, that relationship with the FRC and ERV was more exponential. So for this group, they showed that for each unit of BMI, the VC changed by about 0.5%. So again, you can see they did not include patients with a BMI greater than 40. I mean, our patient was almost double that. I felt a little unsure whether I felt comfortable attributing this restrictive physiology to just obesity. So down the road, he did end up getting a CT. Unfortunately, he didn't have any other more disease. Because they breathe at low lung volumes, very small airway closure. And I remember when I was on the East Coast, a patient came to me very severe sleep apnea, and we had suspicion for OHS. And she told me she had asthma. The term stuck with me since, because we know there's an association between obesity and asthma. These patients, again, there's small airway closure with their FRC close to the RV, and I think it's so challenging to work out in these super obese patients. Do they really have intrinsic airways disease, or is this associated with the weight? And again, this patient was put on bronchodilators and being treated for asthma, so it's really hard. They have increased airway resistance, they have impaired respiratory muscle function, and all of this leads to increased bronchial fluid. Additionally, the obesity seems to diminish the ventilatory response to hypoxia and hypercapnia. And one suggested mechanism is through leptin. So leptin's an adipokine that acts on our hypothalamus, and it basically tells you to breathe and to stop eating. And so we know that in leptin deficient mice kind of mimic OHS. In humans, we have not been shown to have lower leptin levels. In fact, it's, if anything, a little higher. So we think this is probably a problem of leptin resistance or central leptin deficiency because of permeability through the blood-brain barrier. There's a lot of interest whether this could be a potential therapeutic target in these patients. And then sleep disordered breathing, which you guys know I'm passionate about. So hopefully I've convinced you again, most of these patients will have garden variety sleep apnea, but there are clues. And the clues is when I look at the sleep study, it's how severe that sleep apnea, and it's particularly the measures of hypoxemia. If you're seeing them and they're really hypoxemic, you got to think about daytime hypercapnia. And again, there's a proportion less than 10% who don't have the discrete upper airway airflow limitation, but just hyperventilate. And I wonder, is that the distinct subpopulation versus those who have severe sleep apnea? I don't know is the answer. In reality, like everything is probably not so black and white. But this was our patient. Again, we decided to do an inpatient sleep study. And just to show you, this was his study. So just to orientate you, on the top here, so this is a recording from 10:30 to 5 in the morning. Each line here is an event. It looks red because you can see this guy spends more time obstructed than with his airway patent. So this black line is airflow. It's that thing in his nose that looks at breathing. So he's breathing, then he's obstructed. And we know he's obstructed because this line here is a band that goes around the chest that looks at respiratory effort. So he's trying to breathe, he just can't get the airflow past that upper airway. And you can see when he does that, look at his SATs. I mean, you want to give this guy something, right? It's horrible. So we calculate the apnea hypopnea index. So how many times per hour of recording are we seeing these events per night? And so he's ended up being 130, right? It's to tell you, you guys should be ideally less than 5, right? Anything above 30 is severe. So This guy was really severe and he was really hypoxemic. His average SpO2 was 80, his nadir was 53%. So when I saw this study, the severity and the degree of hypoxemia already made me think I have to worry about daytime hypoxemia. This was another study I got told about just recently by one of the fellows, another inpatient study where they had concerns about OHS. So they also went on to do an inpatient sleep study. And you can see they're a little tachypneic, but we don't see the same discrete airflow limitation. But if you look at their SATs, again, they're pretty hypoxemic. So this patient ended up with a sleep study report reporting it the AHI is 3, so normal, but hypoxemic. I was a little nervous signing this report, but I wasn't nervous because I knew the fellow was taking care of it. I didn't want them to assume that this rules out OHS because again, hopefully you'll remember there is a small subset who don't have that discrete airflow limitation, but just hyperventilate. And there's some data that that patient population may actually do worse. Okay. So how is it that the sleep apnea causes in some patients daytime hypercapnia? And it may be because they don't have adequate opportunity to compensate. So you just saw that guy's sleep study. So normally when we have an episode where they can't get the airflow through, can't ventilate, our CO2 goes up. But normally this is followed by usually a little arousal, a little, they try to open up their airways. It's a period of hyperpnea. They're usually able to blow that CO2 down. But you saw our guy, he spent more time apneic than he did with his airway patent. So for him, he may not have adequate opportunity to blow off the CO2 as it's retaining. In addition, we know that the body's response to an increased CO2 is to the kidneys retain the bicarbonate. But the time constant for how the kidneys handle bicarbonate is very different from the time constant for how our lungs handle CO2. So if you have accumulation of bicarbonate, it can somewhat what your ventilatory response. So this was a nice study showing that this accumulation of CO2 may be again due to inadequate compensation. So this took 44 patients who had sleep apnea, and they did overnight sleep studies with end-tidal CO2. And they looked at 3 groups, those who had a maximum end-tidal CO2 less than 45, greater than 50, and in the middle. And what they found was the best determinant of hypercapnia was not the AHI, but it was this interapneic or post-apnea duration, again, saying that they don't have time to maybe compensate for the buildup that occurs when they're. And the other thing just to remember is, so when we talk about CO2, we have the alveolar ventilation equation, and on the top there is CO2 production. We often dismiss it. This study suggests that in these patients, we shouldn't probably dismiss that. So this was a study that looked at, again, determinants of hypercapnia in obese sleep apnea patients. And their hypothesis was that if they were going to look at respiratory parameters, especially ventilation, it was going to be lower in the hypercapnic group than the eupapnic group. But what they found was there was actually no difference statistically in the minute ventilation or the alveolar ventilation. What was different was the CO2 production. So those who had hypercapnic OSA had more CO2 production, although once they adjusted it for the body surface area, it wasn't significant. It suggested, again, weight is probably the reason. Okay, so why do we care about picking up these daytime hypercapnic patients? It's because compared to the eupapnic sleep apnea patients, they do worse. So they have worse mortality. They use more of our healthcare resources, including our ICU. They have more comorbidities, especially cardiovascular. They're more right heart failure, pulmonary hypertension. PH in eupapnic sleep apnea is usually not severe. They have worse quality of life, and then they're more likely to have complications post-op than the eupapnic sleep apnea. I didn't want to spend too much time on the complications, but I did want to talk about this because I think it's so relevant to our medicine folks taking care of these patients. So this was a study, it's an older study, but they basically took all consecutive medicine options over 6 months. And in those that had a BMI over 35, so obese, they did ABGs, PFTs, They follow their hospital course, and they followed them for at least 18 months. And they found that those who had hypercapnia and were obese, so OHS, compared to the eucapnic or obese patients, if they followed them out, at 18 months, they had almost a 23% mortality compared to the 9% who were eucapnic. The scary thing is that you see a lot of the separation happen within 3 months. So that's why for medicine folks, I totally understand you guys calling us to try and get treatment for these patients in a timely fashion. This study, unfortunately, only 23% were actually given a diagnosis of OHS despite this, and only 13% were actually started on PAP. So we want to detect these patients, and they present like our patient. In a third of the times, they will present with acute decompensated hypercapnic respiratory failure. Just like our patients, they're often misdiagnosed with obstructive lung disease, and there's usually a trigger, often it's swallowing, but it can be anything. Ideally, we want to pick them up in the outpatient setting, and hopefully I've given you the clues, right? So weight matters, measures of severity of sleep apnea, hypoxemia, pulmonary hypertension are going to be your clues. I put this up there to remind you that don't dismiss this because they're female. So sleep apnea we know is more a condition in men, at least until menopause. But the study suggests that OHS may be more a problem in men. So this was a study from Saudi Arabia. It looked at almost 2,000 patients that were being referred for suspected sleep apnea. And sure enough, over 1,500 did have sleep apnea. But if you looked at those who were hypercapnic during the day versus eucapnic, you can see it was more females, and particularly postmenopausal females. So again, there may be gender differences. Certainly, again, think about it in your postmenopausal female. And then the other clue I wanted to finish on is the bicarbonate. So when I started, I mentioned that some were interested in including this in the definition. So there have been several studies that have tried to look at the test characteristics of the bicarbonate in OHS. They have some methodological challenges, like they are measured differently. Some measure it's calculated. But in 2019, the American Thoracic Society published clinical practice guidelines on diagnosis and managing OHS. And one of the questions they had in that was, should the serum bicarbonate be used to screen for OHS in these patients? As part of that study, they found that the bicarbonate's real role is in the high negative predictive value. So they suggested that if you have a high pretest probability, then you should go and do an ABG. So our patient, remember his bicarb was 27, right? But there should have been such high clinical suspicion that you should have gone on to do an ABG. But if you have low clinical suspicion and say a BMI less than 30, they said if your bicarbonate is normal, less than 27, it's very unlikely that they have obesity hypoventilation syndrome that you could forego doing that ABG. If it's greater than 27, then they suggest still going. So I'm going to hopefully convince you with the things to think about to diagnose these patients and shift gears about fit and how to manage these patients. So I'll tell you what was done for this patient. So he got put on triple inhaler therapy. So he got put on ICS, LABA, and LAMA. By the time he was discharged, it was de-escalated a little bit. He continued to be diuresed in-house, and then he was put on empiric non-invasive ventilation with oxygen. We had a lot of back and forth about trying to get a device for him, but ultimately he was discharged with an ST unit with an inspiratory pressure of 16 and expiratory pressure of 12, a backup rate of 8 with some oxygen. So the ideal approach to managing these patients, I think, goes to our understanding of the mechanism for OHS. And again, with obesity being so central, I think it's not surprising that really weight loss needs to be a part of this. The other thing I want to just make sure we don't forget is a lot of our treatment studies on OHS often focus on improving hypercapnia as our main treatment goal. These patients have a lot of cardiometabolic comorbidities. And if we've learned anything from the sleep apnea literature is that just improving the AHI may not always address the cardiometabolic comorbidities. So it's something just to bear in mind. So weight loss is effective. So weight loss is being shown in OHS to improve gas exchange, improve sleepiness, improve the sleep disordered breathing, improve pulmonary hypertension, LV dysfunction, improve pulmonary function, and improve the cardiovascular and metabolic comorbidities. I think what's not known quite yet is, well, how much weight are we needing these patients needing to lose? And that may differ depending again on what metric of OHS are you trying to improve. So what I mean by that is the amount of weight loss that's needed to improve the daytime hypercapnia may not be the same as the amount of weight loss you need to improve their comorbidities. And so we don't have a lot of studies in OHS, but there are some studies in our sleep apnea world trying to work out, well, how much weight do you need to lose to improve the sleep apnea? And this was a study by Atul Malhotra. It was a systematic review and meta-analysis. And what they tried to do was quantify the effects of weight loss on the AHI. They used incredibly sophisticated statistical modeling that I don't understand. But what they did try to do was look at the percent change in AHI versus the percent change in BMI. It included over 20 studies, and you can see the main modalities of weight loss were either surgical or lifestyle in blue. So the black dots are surgical, the blue dots are lifestyle, and there's 2 green dots for pharmacotherapy, although we know now since then there's more. And there was a relationship. So if you lost weight, your AHI is much happier. So 10% weight loss, 10% BMI reduction was associated with a 36% reduction in AHI, 20%, 57%. What he found was that the weight loss is greater than 20%. There was a smaller incremental decrease in the AHI. But again, some of this is the grounds for why the clinical practice guidelines came up with this. So again, as I mentioned, we don't have a lot of data in the OH population about weight, but we do know that the greater the weight, the greater the likelihood that the OHS is going to get better. So in their guidelines, they suggested we consider weight loss interventions that produce sustained weight loss of 25 to 30% of actual body weight, which is not trivial. So yeah, that's right. How do we do it? So the good news is our tools to try to achieve this weight loss is getting better. So we know that lifestyle intervention should be part of any weight loss approach, but sadly, lifestyle interventions, most studies show that weight loss is usually less than 10%. For the longest time, people have been trying to find that pill that reduces your weight. But more recently, as we all know, and there's lots of people who could speak far better than this than I can, but we know that there's been a lot of hope with the GLP, the glucagon peptide receptor agonist, and then the dual GLP receptor agonist, which is tirzepatide, showing that these weight loss medications lead to almost a 20% reduction in weight loss. And I just told you that the goal is, over 25%. Prior to these meds, we were really focusing on bariatric surgery, where it's very variable, but the weight loss can be more closer to 25 to 30%. Again, as I mentioned, we don't have a lot of data on these newer pharmacotherapies in OHS, but we're really hopeful based on the SURMOUNT OSA study. So the SURMOUNT study was a study, New England Journal, showed that tirzepatide led to, again, about a 20% reduction in weight. So the SURMOUNT OSA study was a study that took obese individuals who had at least moderate sleep apnea and they had an AHI 15 or greater. They didn't have diabetes, and they were randomized to receive tirzepatide at either 10 or 15 milligrams or placebo. And this is in conjunction with lifestyle. And the lifestyle was pretty strict. If you read it, I would have failed. And it was for a year. And there was 2 parts to this study. So the first included patients who are either unwilling or unable to use the CPAP. And the second trial included patients on positive airway pressure for at least 3 months. And the primary outcome that they looked at was improvement in the AHI. And the secondary outcome endpoints are shown here, including changes in weight, hypoxic burden, patient-reported sleep and some cardiovascular models. So the study population, you can see we're largely middle age, more men. The mean BMI was about 39. They had severe sleep apnea, so you can see their AHI was over 50. So the ESS is the Epworth Sleepiness Scale. So for those of you who come to the sleep clinic, we do it routinely. 10 is what kind of is used to divide sleepiness. So they were mildly sleepy. You can see they had a lot of cardiometabolic. And this is what they found. So on the top is the effects of tirzepatide on the AHI. On the bottom is weight. The left is those not on PAP. The right is those on PAP. And you can see, like prior studies, there was about a 17%, 19% change in the BMI. And associated with that was an improvement in the AHI. But what I wanted to highlight is that there was a 25 reduction in the mean and then 29 reduction. And I just told you the AHI starting off was over 50. So this definitely improves the sleep apnea, but you just have to be mindful. It may not get rid of it completely. So a lot of patients always come to me, well, that's great. Will this get me off the CPAP? And I usually say it may not be. So, yeah. And then again, as I mentioned, bariatric surgery is always another tool. There's various approaches, and again, the weight loss that's achieved surgically is greater and more sustained than lifestyle. It varies depending on the procedure. The more effective tend to be the actual bariatric surgeries, where again, as I mentioned, maybe it's about 25 to 30% weight loss in 12 months, but variable. The other good thing about bariatric surgery is that it seems to improve the metabolic and cardiovascular comorbidities. So it targets that as well. But it's obviously not a procedure without risk. And similar to the pharmacotherapy, it helps the sleep apnea, but it may not get rid of it. So this was, again, another systematic review that looked at studies looking at the impact of bariatric surgery on the AHI. And you can see that the mean reduction in the BMI was about 12. The mean reduction in the AHI was about 19, and they started with a pre-surgical AHI far greater than 30. So in this systematic review, they said that about 65% will have remission, but not, again, that leaves a significant portion that still has some sleep. Okay, take a sip. So again, weight loss is great, but it's not perfect. It's hard. It takes time. So we don't want to delay treatment, and our main treatment is positive airway pressure. It works. So it helps, again, the hypocapnia, improves symptoms, it improves the sleep disordered breathing, it improves sleep architecture, it reduces hospital admission. So it is effective. But the question you guys will ask me, well, that's great, but what positive airway pressure mode and what device do I need to get this patient? And like everything in medicine, the menu is just getting longer and longer. Yeah, it's just harder being a medical student now because there's so much more information. I will hopefully convince you that the mode will depend on the acuity of the presentation. And hopefully I want you to think about the phenotype, the group with sleep apnea and the group without. Now, once you decide on the mode, that should really govern the device you're going to get the patient, right? The device that delivers that mode should depend on medical needs. Sadly, in the US, unfortunately, reimbursement criteria are a real barrier. I get more questions on how to get a device than any medical question. It's so sad. It was the thing that drove me to write my first paper ever as a fellow was on reimbursement for PAP devices. But it is just how it is in this country. And you can still call me every time, but it's challenging. But the medical side, I'm comfortable with. So in those who are stable with severe sleep apnea, we now have several observational and RCTs that have tried to compare CPAP to bilateral. The biggest of these studies is the Pickwick study. So this was a study out of Spain. It was RCT. And they took patients with obesity hypoventilation syndrome and they phenotyped them. Okay. So they took the ones who had severe sleep apnea and they were randomized to lifestyle. I don't know how, but they did CPAP or non-invasive ventilation. And the primary outcome that they looked at was improvement in gas exchange, so improvement in hypercapnia at 2 months. After 2 months, those in the lifestyle group were re-randomized to CPAP or non-invasive ventilation, and then they were followed out for about 3 years. And the primary outcome that they looked at there was a number of hospitalizations. They did a second study, which took those who didn't have severe sleep apnea. Again, I don't know how they did this, but they were randomized to just lifestyle or non-invasive ventilation, and they were followed with the primary outcome, again, being hospitalization. Just for the pulmonologist in this group, so the NIV mode that was used in the study was actually something called volume targeted pressure support. Again, this was done in Spain, so they used more traditional mechanical ventilators, but it's just to kind of show you that these studies are somewhat challenging because the mode of NIV is different among studies. So the study group were predominantly, again, female. Hopefully I've shown you today, don't dismiss females in OHS. Mean age was about 60. They were obese, right? The BMI was over 40. And the PaCO2 was about 50 in this group. And what they found was that both NIV and CPAP led to improvements in PaCO2. So compared to controls. Now for the CPAP group, it was significant only after it was adjusted for adherence. But what they found also was that comparing NIV and CPAP, there was no significant difference in improvement in PaCO2. Again, these patients were followed longer for a median of just over 5 years. And again, comparing CPAP to NIV, there was no difference in the hospitalization days per year. And similarly, there was no difference in cardiovascular events and mortality. Again, in this severe group, CPAP and NIV seemed comparable. As I mentioned, they did look at the group without severe sleep apnea, although if you look at this population, they still had moderate sleep apnea. This group was, again, predominantly female. They were a little older. The BMI was still high, and the mean PaCO2 was about 49. And what I found surprising is that at a median follow-up of close to 5 years, there's actually no statistically significant difference in hospitalization days per year between those who received NIV and those who didn't. Now, there was a lot of criticism in this study that the adherence may have been an issue. So CPAP or PAP is only as good as if it's on you, right? It doesn't work if you don't put it on. So the adherence in this study was about 3.6 hours, so it's not great. And that's one of the reasons they've suggested might be the for the what we're seeing. So again, I think just as important when we're deciding the mode is, well, what is your patient going to be comfortable with? And there's multiple studies now showing that adherence matters, including this one from Lebec, who took close to 75 patients, and he looked at determinants of improvement in hypercapnia, and it was adherence. So if you compared those who used their PAP device for more than 4.5 hours compared to less, the PaCO2 improved by close to 8 versus only 2. So he found for that every hour of adherence, the PaCO2 would drop by 1.84, and I think the PO2 went up by about 3. So make sure you get your patient a device, a mask that they're comfortable with and use. It's probably the most important. So based on all this data, the guidelines are that if you have a stable outpatient OHS patient with the severe sleep apnea phenotype, that you can probably start them on just CPAP without it. So you guys will then ask me, well, when do I need to use NIV? These are the groups I think about NIV in our patient. The ones who present decompensated with acute hypercapnic respiratory failure. Hopefully I'm going to convince you again in that subset without sleep apnea, you're going to think about NIV. And then some people, the CPAP doesn't work for various reasons, including sometimes the pressures that are needed are really high and they can't tolerate it. The one thing I will say is sometimes you'll call me the tech will call me in the sleep lab going, TCOM's still high after a night. What do you want to do? Sometimes you just need to give it a little time. So there's studies suggesting it can take up to 6 weeks, sometimes with improvements. So patients. And then if there's another reason for them to be on NIV, especially for the pulmonologist, is there an overlap syndrome with obstructive lung disease, some other reason, then let's be for that NIV. And so again, the same guidelines suggested in our patient scenario, hospitalized patients with respiratory failure suspected of having OHS, that they should be started on NIV or being discharged from the hospital. Until they undergo an outpatient workup and titration of PAP, ideally within the first 3 months of hospital discharge, which is great, but we all know access is a challenge. What they also said is, if you can't do that, at least discharge them on some auto CPAP, like give them something to go home on. Okay, we don't have a lot of data to guide these guidelines, so for that reason, this same expert consensus panel convened and they did an individual patient data meta-analysis. And they looked at over 1,000 patients in 10 studies of hospitalized patients who had OHS or suspected OHS and were discharged from hospital. And what they found was that most of them were discharged on PAP, majority being NIV, and they had a significantly lower 3-month mortality than those who didn't, with an odds ratio was 0.16. So on this basis, again, they really suggested these patients who are decompensated. And I showed you that study from Nova, right? 3 months, they're not doing well. Please call us to help you get a device for this patient. The other common pitfall I'll see is that often I think it's instinct in the ED, sometimes to slap on NIV 10/5. But the data would say in these patients, they're often needing, based on these clinical trials, an inspiratory pressure of 18 to 24, an EPAP of 8 to 12, and a backup rate of 14 to 16. Again, they have rapid shallow bleeding. So the other common mistake I sometimes see is they're not tolerating it because you're probably not giving them what they need. So this is my summary slide. So if they're acute, unstable, hopefully I've convinced you, you really want to put them on NIV. If they're chronic and stable and you phenotype them to have severe sleep apnea, it's probably okay to do CPAP. If they're that small group who don't have OSA but just hyperventilate, you're going to use NIV. But all of this has to be really close follow-up because it's possible there are studies showing that many of patients who are unstable can probably be transitioned to CPAP, but there's also some folks who don't do well and you're going to have to transition them to NIV. Okay. Let me just quickly touch on 2 things I get asked about oxygen. So it is tempting to put on oxygen in these patients, right? They are smurfs, like you just want to give them some oxygen. But you just have to be a little careful. So there are some short-term crossover studies that show that even short periods of oxygen can worsen hypercapnia in these patients. So my one take home is it's okay to give oxygen with the positive element, with the non-invasive ventilation. And up to half of these patients will need oxygen with the NIV, but often that need abates with time. So just be a little careful. The other common thing I see is don't be totally comforted by a trach. And this is rarely seen. The most common scenario I see for trachs is someone comes in decompensated, they end up intubated with a trach discharge. And usually the question I get is, I want to decannulate them. How can I get them off? So we don't have a lot of data on the trachs. What we do know that is that it may not resolve the hypercapnia in all these patients. So I think this goes to the fact that, again, a lot of people think, well, I bypass the upper airway obstruction, so why won't the hypercapnia improve? But hopefully, you guys know this is just not everything. So they still hyperventilate. So the common mistake is they're still hypercapnia and no one's ventilating them. So again, just to be mindful of that. And then I leave you with this. So it is important to follow these patients, and we're not good at it. So this was, I think, another Spanish study. It was looking at how effective NIV was for acute decompensated hypercapnic respiratory failure patients from both COPD and OHS. COPD on the left and OHS on the right. And what it found was that actually NIV seems to be just as good in the OHS population as it is for COPD, but you can see the follow-up was pretty humbling. So this is a year after they were discharged. And again, these patients were admitted decompensated, needing NIV, and only 55% were still on positive airway pressure. So it's and this is being repeatedly shown, we're just not great at keeping these patients on the positive blood pressure. But we have a success for our patient. So he was started on tirzepatide through our obesity clinic. And this was immediately post-discharge, and what he's looking now, for those of you not familiar, this is data from his CPAP machine or BiPAP machine. So this is his usage each line, and this is his AHI. So remember, he was over 100. Now he's looking like he's less than 2. And that was his last scan. He's probably got a metabolic alkalosis now, but his hypercap is good. So I'm gonna finish there. Hopefully I've convinced you that we can improve diagnosis, and I hope to have convinced you that the weight, measures of hypoxemia, and the bicarb may be clues that we really need to phenotype these patients to guide treatment. We do that with the sleep study, and that weight loss needs to be central in managing these patients using a multimodal approach, ideally targeting weight.
Thank you, Frank. That was terrific. At one point, it sounded, I thought I heard you say you were surprised that mortality was unchanged between the CPAP and the NIV groups in one of the studies there. And I was wondering.
It was NIV versus nothing.
Versus nothing. Okay.
Yeah. Not the CPAP. That was those. So the Pickwick did a group where they took patients who didn't have severe sleep apnea, and they were randomized to NIV or lifestyle.
Right.
And that's where
I mean, there are like a lot of longitudinal data of Wisconsin and elsewhere that really show the risk of mortality is really clustered in the folks with severe. So
yeah, and there were differences in what that mortality was. So in the NIV, the mortality was due to cardiovascular events, whereas the placebo group, it was still respiratory.
Very excellent presentation, very thorough. On the data that you showed on the adherence report, it showed that the AHI was good, but the leak was substantial. And I think it goes back to what you said, which is CPAP and NIV is like sex. It's not the equipment, it's technique. And when technique is not good and there's a lot of leak, you get ineffective ventilation, and the hypercapnia may persist when you've got a lot of leak. So I think that's something that we sometimes overlook.
Yeah, leak is definitely sometimes a challenge, especially at the higher pressures. It is something that we have to try to work on. But absolutely.
Every time I hear this or like any talks by you, I feel like I learned something. But in terms of your treatment algorithm, you said that in the outpatient setting, after you discharge someone on NIV, you can potentially down titrate or down switch them to CPAP. Is there any downside to just leaving them on NIV if they're doing
Probably not. Probably not. Yeah, a lot of it also goes to, some of it is questions regarding resources, and different countries have different funding models for these devices. And so from a medical perspective, there's probably not a cost. I mean, I won't go there.
And for the patients who have overlap, where they have OHS and the phenotype with OSA, are you doing repeat sleep studies, or are you just looking at improvements in PCOS?
So I don't go just by the Dallo data, right? So that may still not capture those who just do the hyperventilation. And there's various ways to look for that. I think the most reliable and sophisticated way is always to do a titration sleep study in the sleep lab, where we have the option of looking at CO2 measures. At our sleep clinic, we tend to use the transcutaneous CO2 measure. So that's, I think, the most sophisticated way, because of the challenges of access, and some people just don't want to come in. The other thing you have to be mindful is always here, well, sleep will do an in-lab sleep study. We have a weight limit for our PSGs. It's 400 pounds. So people always say, well, they'll just do, I get it into the lab. They don't, our beds won't allow for it. So there's other ways to try and do that. We often use oximetry as a measure of adequate ventilation, understanding and it's not perfect. So sometimes we'll do that and titrate.
Cliffy's Willick, a number of years ago, was looking at patients with comparable weights, some with hypercapnia and others that don't have hypercapnia, looking at drive or E50 or something to compare those two phenotypes. And have you looked at that and thought about
A lot of
that?
these studies do control, so they try to match for the weight. But even though it's matched, they're still showing reduced hypoxia. Most studies do try to match.
But there's a segment of patients who are obese that don't have hypoventilation, and then there's those that do, even though the weights may be comparable. You know, why is that? Why do some people sort of escape the bullet? Phenotype is sort of a descriptive term, but the mechanism of drive might be important.
Obviously not talking about teaching for the fellow.
No, I hope my question's kind of simple, Bernie. Thank you. For the talk. I agree with Megan. I always learn something. Is there some sort of time period that you would obtain a arterial blood gas? Because you alluded to this earlier, but a lot of these patients show up decompensated into the hospital. Is there, similar to like the COPD data, do you wait a certain amount of time for stability, or is there some data showing like when you should do
I think it really goes clinically. I will say it's hard to, people don't like getting blood gases. It drives me a little nuts. I will ask for it. I think once you have a sense, then I feel more comfortable using the venous gas, maybe to trend it. But I really like an arterial blood gas cell. And then again, it will go clinically as to the frequency. But sometimes I use the venous gas once I know more for a trend.
Okay.
I also think as an outpatient, we're not great at getting them. I will get them. The problem is it's not part of our sleep lab, so they have to go somewhere to get it, which is not.
Thanks.
There's like, I have a million questions to ask every time I see you. But no, for this, I know everybody's so excited about the dual agonists. Are you guys prescribing them in the sleep clinic yet? And then also, when do you think the right time is? Like, do you prescribe it like right at the diagnosis of OHS, OSA? You give like CPAP for time to work, or like where do you see that going?
It's a great question and a topic of a lot of back and forth within our group. So again, it's not being really studied in the OHS patients. After the SURMOUNT OSA study, we definitely have patients coming to us wanting a sleep study to meet one of the criteria for getting these. I don't need to tell this group access is a problem for us. And so, again, I do think for this group, for the OHS group, for this patient, absolutely, I think it makes sense to try to initiate these meds. For those who are less like just eucapnic sleep apnea, there's mixed feelings in our group as to if we should be the ones prescribing in that. Part of it is just the resources, to be honest. Like these meds are meant to be complementary with lifestyle, right? And that takes time to do the counseling, to do the follow-up. And most of these patients have multiple indications for the meds. It's not just the sleep apnea. They have diabetes and metabolic complications. And so within our group, there's some back and forth. Are we the best people to do that? I don't know the answer. I'm sure everyone is strapped in that clinic for time and resources. So I don't want to punt it, but we are. But for this group, for the OHS group, I do think while we don't have the studies, weight is so important, and they have so many cardiometabolic comorbidities. And we know that trying to achieve that weight loss isn't going to happen with lifestyle. That yes, we have. Okay, well, thank you.